For decades, colorectal cancer was considered a disease of older adults, and screening guidelines reflected that assumption by starting at age 50. That picture has changed dramatically. New data from the American Cancer Society, published in CA, a cancer journal for clinicians, has identified a clear and accelerating shift. Colorectal cancer rates are falling in adults over 65 but rising in adults under 65, with the sharpest increases concentrated in the youngest age groups. More importantly, the data has pinpointed which part of the colorectum is driving the trend. Rectal cancer, specifically, is fueling the rise, and it now accounts for 32% of all colorectal cancer diagnoses, up from 27% in the mid-2000s. Three oncology and epidemiology researchers explain what is known, what remains unknown, and what younger adults need to watch for. The scale of the problem. Colorectal cancer is the third most common cancer in both men and women in the United States, and the second leading cause of cancer-related death overall. In adults under 50, it has become the leading cause of cancer death, surpassing all other cancer types in that age group. The staging data makes the situation more urgent. 3 out of 4 colorectal cancers diagnosed in adults under 50 are already at an advanced stage at the time of diagnosis. This means the window for early, more treatable detection is frequently being missed, often because younger patients and their physicians are not considering colorectal cancer as a likely explanation for their symptoms. Andriana Holloway, HD, young adult cancer researcher and assistant professor of hematology and oncology at Vanderbilt University Medical Center, describes the shift as alarming. Colorectal cancer has historically been an older person's disease, and its increasing prevalence in younger populations represents a meaningful departure from the pattern that defined it for most of the 20th century. Why the rectum in particular? Rectal cancer develops in the tissues of the rectum, the final 6 inches of the large intestine before the anus. The majority of rectal cancers are adenocarcinomas, meaning they arise from the glandular cells that line the inner wall of the rectum. Michael Hall, MD, Director of Gastrointestinal Risk Assessment at Fox Chase Cancer Center, explains that the risk factors for rectal cancer and colon cancer are largely the same, but something about the cellular environment of the rectum appears to make it particularly susceptible to whatever exposures are driving the early onset trend. The data showing that the increase is concentrated in the distal colon and rectum rather than distributed evenly across the entire colorectum is scientifically significant. It suggests that whatever is causing more cancers in younger people is not affecting the entire colon uniformly, which in turn points toward factors that interact specifically with the microbial and chemical environment of the lower gastrointestinal tract. The gut microbiome is densest and most metabolically active in exactly this region. The generation born in 1990, research published in the Journal of the National Cancer Institute, provides one of the most striking data points in this area. People born in 1990 are twice as likely as those born in 1950 to develop colon cancer, and 4 times as likely to be diagnosed with rectal cancer. This generational pattern is what makes the current rise so difficult to attribute to a single cause. Something has changed in the environment, diet, or lifestyle exposures of people born in recent decades compared to those born in the mid-20th century, and researchers are working to identify which changes are most responsible. Hall points to higher consumption of processed foods and sugar, along with gut microbiome disruption, as plausible contributing factors. The microbiome hypothesis is particularly compelling given the anatomical specificity of the trend. Processed food consumption and dietary patterns that reduce microbiome diversity affect the lower colon and rectum more directly than other parts of the gastrointestinal tract, because it is where fermentation and microbial metabolism of food residues is most concentrated. Heather Ox-Balcom, PhD, Associate Professor of Epidemiology at the University at Buffalo, highlights abdominal obesity as another factor with growing evidence. Colorectal cancer is a recognized obesity-related cancer, and recent studies have specifically linked abdominal fat distribution, rather than overall BMI alone, to elevated colorectal cancer risk. The mechanisms likely involve insulin resistance, elevated circulating insulin and IGF-1, and adipose-derived inflammatory cytokines that create a tumor-promoting environment in colorectal tissue. Holowati is careful not to oversimplify the explanation. Environmental factors that drive systemic inflammation are suspected, but the increase in early-onset rectal cancer is almost certainly multifactorial. It likely reflects a combination of known risk factors acting in concert with exposures that have not yet been fully characterized. Researchers across multiple institutions are actively investigating what changed for people coming of age after the 1970s and 1980s that did not affect earlier generations in the same way. Recognizing the symptoms of rectal cancer overlap significantly with those of colon cancer, and many of them are easy to attribute to less serious causes. Bowel habit changes that persist for more than a few days, including diarrhea, constipation, or stool that appears narrower than usual, should not be dismissed. The sensation of incomplete evacuation, the feeling that a bowel movement is still needed after one has already occurred, is a particularly specific symptom of rectal pathology. Rectal bleeding with bright red blood, blood in the stool that makes it appear dark brown or black, cramping or abdominal pain, unexplained fatigue, and unintentional weight loss are all warning signs. Blood in the stool can be easy to miss initially, but even when not immediately visible, ongoing slow blood loss accumulates over time and can cause anemia. Anemia, detected through routine blood work, is recognized by the American Cancer Society as one of the first detectable signs of colorectal cancer and should prompt further investigation, particularly in younger adults without another clear explanation for it. Research shows that nearly half of patients eventually diagnosed with colorectal cancer reported blood in their stool before diagnosis, and 40% had abdominal pain. Despite this, it can take up to 6 months for younger patients to receive a correct diagnosis, partly because physicians and patients alike are less likely to consider colorectal cancer in someone under 50. Reducing risk and getting diagnosed early. Some colorectal cancer risk factors, including family history, inherited gene variants, and personal history of inflammatory bowel disease, cannot be modified. But several behavioral and dietary factors that appear in the same data driving the early onset increase can be addressed directly. Maintaining a healthy body weight, staying physically active, eating a diet rich in vegetables, fruits, and whole grains while limiting red and processed meats, limiting alcohol and not smoking, all reduce colorectal cancer risk through overlapping mechanisms involving inflammation, microbiome composition, insulin sensitivity, and carcinogen exposure. The most important message from all three researchers is the same: do not dismiss symptoms. If blood appears in the stool, bowel habits change persistently, or abdominal pain develops without a clear explanation, seek medical evaluation promptly and advocate for appropriate testing. The survival rate for colorectal cancer caught at an early stage is dramatically better than for cancer diagnosed at an advanced stage, and the current data showing that 3/4 of cases in younger adults are already advanced at diagnosis reflects how often the window for early detection is being